What's up, YouTube? We have a special show today. This is an impromptu show, a little bit out of my normal streaming time. But I have with me today my good friend Phil White, who has joined me to talk FAI hip, femoral acetabular impingement. We're going to be breaking it down, telling you the do's and don'ts. How are you, Phil?
Very well. Stoked to be back on a call. It's been a while.
Been a while, hasn't it? Yeah.
Yes.
You've been traveling a bit lately.
Yeah. Country England, not famous for its good internet, so it's a bit tricky. So pleased to be back.
Yeah, nice one. So today this show is actually, we're doing this to answer a question of one of our members in the Unify movement system in the online personal training. And Michael has said, he's told me that he has just found out that he has FAI hip, femoral acetabular impingement. I've actually got this myself as well. So I'm interested to hear what Phil's got to say. And this is the message that he sent me when I asked him, when do you feel the pain? Is it constant or only after activity? And he said, normal day-to-day activities is not a big deal at all. Anytime I straddle something or step over something laterally, like over a small fence, really anything where my legs spread apart, I feel tightness, limited range of motion, and some pain and discomfort in the end range. If I play pickleball for a couple of hours, the pain does flare up a bit for a couple of days, and also I get pain on the outer side of my butt, like where it dimples, sort of. Hard to explain, I just want to feel normal again when I play sports. What do you propose? So that's the question, that's what we want to answer. So Phil, do you want to, maybe if we start off by telling us what FAI hip is?
Yeah, for sure. And we'll start this by, just like Rad, I've got FAI as well. And I'd be very surprised if sort of most people in the audience wouldn't have some level of changes that can lead to FAI. And this is where it's really important to understand the difference between morphological changes. So that's changes of the structure of your body that aren't, I guess, ideal. And then when that actually turns into a condition and when that turns into an injury and impairment, because you can have changes to structure. So you can have arthritic change, you can have things like FAI, the contributors to FAI, which we'll go through in a second, but that doesn't necessarily lead to pain or issues. And this is where that kind of clinical diagnosis, and we've talked about this quite a few times on past podcasts, of like, that's why going straight for a scan might not always be the best idea, because when it comes to FAI, the different changes that can happen will be seen on probably most people who have done sport in their younger years. And if you just get a scan and don't have any of the clinical diagnosis that goes with it, you might find, hey, I've got these, cartilage or bone changes, and therefore it's that's causing the issue. Where in most people, it is actually asymptomatic when you have these changes. So just something really important to understand.
And probably a good thing for me to say as well, because there will be some of you out there who don't know who Phil is. Phil is a good friend of Yanni and mine. He used to work with us at Unity Gym when we had the location. Phil's been giving us sports massages for well over a decade now, and is a physical therapist, what you call them in America. In Australia, we call them physiotherapists. But that is what Phil's formal education is, and he's worked with some of the greatest athletes in the world, people like Hafthor Bjornsson and Sebastian Oreb, and also with some of Australia's leading football clubs, the GWS Giants, most notably. So Phil's got a really...
I unfortunately never had the pleasure to work directly on the mountain, but yeah, I worked really closely with his coach for many years, and now I'm like involved, but didn't get to work on that huge human.
Yep. So if you are watching live and you have questions and the reason why we work so closely with Phil as well is that Yanni and I have a really strong belief that when you see a physical therapist or a physio, that you should work with somebody that has skin in the game, somebody that's actually out there themselves and who understands what the importance of getting back to full function is, because the way that what I've learned from Phil about injuries has just gone so far beyond what the prescription has been from other physical therapists that I've seen, and from what other members have gotten from physical therapists. So if you're serious about sports, if you're serious about getting back to what you love and you have FAI hip, then listen up, because this is going to be good. So sorry, Phil, you can continue now.
Yeah, so I think it's important to first start off with what that word means. So femoroacetabular impingement. Femoro is talking about the femur, so that's the thigh bone. The acetabular is talking about the actual hip socket. And then impingement is the closing down of space. And I've actually got this app set up, which should hopefully work if you're
Perfect.
watching the YouTube video. If you're not, if you're on the podcast feed, then maybe worth checking out the Instagrams. The YouTube. Okay, so you're able to see here as I move it.
Yep.
Cool. So this is the hip. It's a ball and socket joint, and we can see that big thigh bone. That's the femur, and where it connects into the body is the acetabulum. So that's the socket part of the hip. And when we talk about impingement, it's the closing down of the space in between that ball and in the socket. So the interesting thing with FAI is it usually has quite a different mechanism for women versus men. It's not always the case, but it's very common that the morphological change that causes FAI in women is a bit different to what happens in men. So in men, what typically happens is you get a thickening of the neck of the femur. So this part here, where it goes from the main long shaft of the bone, then it goes into the ball, there's what's called the neck, and you get what's called a cam deformity, which is where bone is growing on the growth plate here as you're developing, as if you're playing lots of sport, if you're stressing your bone by doing multi-directional things like playing soccer, playing football, playing any sport where you're doing lots of change of direction, your bones adapt to that stress by basically thickening at the area of the growth plate. So that neck becomes instead of looking quite tapered here, it actually has a big bulge that comes through. And then what happens is once that is in that position, if you don't have too much active control around your hip joint, so if you've got a bit older, you're sitting down all day, you haven't got too much muscle mass around the big prime movers of the legs, so the quads, your hamstrings, your glutes, but then also you haven't got good active control on your stabilizers, so your glute medius, your external rotators, then what can happen is you start to get a bit more of like a gliding and unwanted movements of the ball in the socket, and that can lead to that where that growth plate is thickened and you've got this bulging bone there to then cause a closing down of the space in that hip joint. Does that make sense?
Absolutely. Yep.
Yeah, so unfortunately this model I can't move it around, but hopefully for people who are watching online that makes a bit of sense, where instead of being tapered here on this neck, we've got this kind of big bulging thing, which is that cam deformity, which is most common for men. Now with women, as I said, it's a bit different, so I'm just going to hide the femur here. Let's get rid of that and we'll go into the acetabulum. So if we think about that socket joint, what can happen with women is if you're doing lots of, it can be a similar mechanism of sports like that where you're doing kicking or changing direction, but also I think it particularly is prevalent in sports where you're doing maybe more range of motion, so dance or gymnastics, where it starts to basically cause a similar thing where you're irritating the front lip of that bone, and then you start to get basically an overgrowth at the front there of bony and cartilaginous structures that then means that, as you can imagine, when we bring back our hip, come on, magic hip, where are you? There we go. So if we've got a kind of overgrowth in that bone, in that hip space, sorry, bring it back up. If everything's a bit thicker through here, then any amount of forward glide in that socket is going to cause a irritation and the closing down of the space, and therefore impingement. So hopefully just understanding those anatomical structures and seeing a bit of how that mechanism could happen gives you a bit of an understanding of just what we're talking about here, and then will make more sense when we talk about the actual management. Yeah,
absolutely. And so yeah.
So I was going to say, and this is where I think it's really important to differentiate. When I talked about FAI is the injury and the actual impairment, but you can have those morphological changes. So the cam type deformity on the thickening of the neck for generally in men, and the overgrowth of the labrum, in the acetabulum, which is the pincer type deformity that is a technical term. You can have those without any pain or dysfunction. So that's again where it's really important that you don't just rush to get a scan without any context and any clinical diagnosis, because if you see that and you think, oh gosh, I can't possibly load my hip and I can't possibly use my hip if I've got these bony changes that aren't meant to be there, then that can really lead you down a path of disengaging from exercise, being scared of movement, being scared of loading, and that's the worst possible thing you can do. So
yeah,
really
I didn't even know that I had FAI hip until Leroy diagnosed me, and that was when he came over to help me with my meniscus tear, and he was just looking at my hip and he went, "Oh, you've got femoroacetabular impingement," and I went, "What? What's that?"
Yeah. And as I said, we planned to do the podcast last week, and I had all these numbers ready, but basically it's a really high percentage of people, particularly if you have played sport in your younger years, you're almost guaranteed to have it. And I think it's important to see that as like, cool, your body adapted to what you're doing, and now we've just got to make sure that over our lifetime we're just providing the hip with its best chance of functioning well, and that's going to be by having really good, strong, active structures that mean that the ball isn't going to get that unwanted glide around the joint.
So what are the signs and symptoms of FAI hip? Like, what can you expect?
Yeah, so it's really classic when you get pain in like sitting for long periods of time, front of the hip pain that can sometimes be around the groin. It's often the way with these like joint conditions that it's not often just at like pinpoint one spot. You can get these sort of referring pains that go to different sort of unexpected places, but it's really common around that sort of groin and front of hip area. Often in, I guess, positions where you're in deep knee flexion, adduction. So adduction is bringing if you were to cross your legs, if you were sitting at a table, like sitting in a chair and crossing your legs, kind of like that classic like secretary look, that would be adduction. And then internal rotation, I know for you and your experience with FAI, it was that forcing internal rotation that really, really aggravated it. So, and that's actually one of the clinical tests is if you're painful on flexion, so bring your knee towards your chest, you bring it across your midline, and then you internally rotate. That's if you aren't painful on that, then you definitely, it's very likely that you don't have FAI. And this, I won't go into the details of specificity and sensitivity in the science of diagnostic criteria, but basically you may be painful in that position and not have it, but if you aren't painful, you definitely don't have FAI. So that's the shortest I could make that.
Okay. Interesting. Yeah, cool. Okay.
That's and classic position. So as you experience, is that like that internal rotation is often really aggravated, and that's where I think one of the challenges that people run into with these kind of things, and culturally how many people approach injuries is thinking that range of motion and stretching is always inherently therapeutic, and that's where it's so important to know. Like if you do not have good active control of that hip, and then you're just jamming end range of motion, though that's when you're kind of causing that aggravation, because you're basically using those anatomical, that variation that you've got is now you're basically forcing an impingement.
Yeah, I mean, that's how I found out about it, because this was early on in my flexibility days, and all I'd really done to learn about the methods that we now teach with flexibility, I'd done a workshop with Ida Portal over a weekend, and I learned a lot of really cool flexibility movements and a lot of things that I hadn't seen before. And of course there was no assessment for me personally as to what would be best, and one of the movements was this loaded hip internal rotation, and I really worked on it and I wasn't getting any better, and so I tried to force it, and one day the inside of my knee just started to hurt, and it didn't go away, and it started to hurt on different things that I was doing, and eventually I did it the opposite way around. I just went and got an MRI, and the MRI said that I had a meniscus tear. And fortunately for me, this was before Phil was a physical therapist, but somebody who was actually one of Phil's mentors. Was he one of your mentors? Is that what you'd say? Is that what you'd call him?
Working with Leroy? Or?
Yeah, working with Leroy.
Yeah.
Was he a mentor? Yeah. So Leroy was a mentor of Phil's, and he's an exceptional physical therapist, and he came down to see me, and he just looked at me and said, "Man, how did you tear your meniscus?" And I said, "I don't know, man. I don't know what I've been doing." And he looked at my hip and said, "Oh, you've got FAI hip." And I asked him to explain what that means. And his very short explanation, he said something similar to what you've said, but he said it very, very quickly. And he said, "But basically for you, hip internal rotation and hip extension are always going to be restricted." And they are. Like, those are the two movements that for me, despite my best efforts, I just haven't been able to get better at. And he just said, "Yeah, you won't be able to. You know, your hip's basically just going bang, bang and hitting up against something." And I explained to him what I was doing. And he said, "Oh man, you've been trying to force that position loaded, and you're getting lateral flexion on your knee, and your meniscus is torn from too much wear and tear." So yeah, I'm just saying that to reinforce what Phil's just said about this idea of, you know, being aware of what you can and can't do, and not trying to force it.
And again, not forcing, particularly with stretching, because again, people think always that like, oh, like that's the most common thing when I say what do you think is going on? What do you think has caused your injury? And people are like, oh, I'm not warming up enough and I'm not stretching enough. And they're the two things that people always claim as the main reason that they've got an injury or they're in pain. And it's, from my point of view, never those things.
Yeah.
It's always, and stretching is almost, you got to treat range of motion, particularly with hip, like with joints, that's when you're making things most aggravated, is when you're really pushing to end range because you're closing down joint spaces. So not always therapeutically best option.
Beneficial, yeah. And so let's talk treatment now. So, Michael's asked for, do I need any modifications to my program now that I know that I have this problem, and based on the signs and symptoms that he's presenting with?
Yeah, so I think the first one is really positive that it's not aggravating in general everyday activities. That's excellent. So the first sort of thing that I think about with managing injuries, obviously bringing down the aggravating factors and then trying to work within our capacity, like our current capacity, to do close to optimal training as possible, and then gradually reintroduce, I guess, what we need to be able to do those things that are aggravating. So for him, it's going to be, unfortunately, with pickleball being an aggravating thing because of that lateral movement, it's probably we want to let that joint settle down a bit. So maybe playing either like less intense games or playing doubles instead of singles, something where it's basically toning down that a little bit, because if we're continually aggravating it, you really sensitize the area, and then basically everything can become really painful if everything's sensitized all the time. But for most people with FAI,
could you also reduce volume of games played? Like if he's playing 3 nights a week, certainly. If he goes down to one day a week, would that make a difference?
Yeah, so it's going to be one of those things where you think about the different variables involved, whether it's like how fast and how intense you're going, whether it's how long you go for, if it's frequency, if you go kind of back-to-back days versus days in between, and thinking, okay, what am I feeling the symptoms ramp up the most with, and can I, turn that down in whichever of those variables it is. But my thinking is always like try and if it's not something like acutely terrible, is like, can we try and stay engaged, keep your momentum going, and keep enjoying what you're doing. So ideally try and keep some level of pickleball, whether that's, if you can't play games, even like practicing ball skills by hitting against a wall and staying moving, because it's basically, when thinking about those hip joint movements, by doing small sort of side steps, that's going to be training those muscles and getting those stability things going without aggravating. So that's on the like aggravation modification side of things. So we want to try and turn that down. If you're in the gym and you're finding, often for people with FAI, it's deep squats, it's like rear foot elevated split squats, like anything where you're getting into that, again, sort of deep hip, like the deep hip extension, forced hip extension kind of things, and any deep hip flexion. So in the gym, you might need to modify those, but that's not to say that you can't do any type of squats or you can't do any types of single leg work. It's just thinking, okay, if we know that range of motion is the most aggravating variable, can we choose exercises that are less closing down on that space? So for a squat, for example, if you're doing low bar squats, that's a very hip dominant squat, and you might find that doing parallel knees elevated like front squats or high bar could be a really nice option. If you're on leg presses, for example, just changing the position of your feet to like changing the angles, so you're basically not going into that position of aggravation.
Yep.
And then thinking about when it comes to that structural balance that we're looking for in the hip, of trying to build up the optimal levels of strength in not only our moving muscles but also our stability muscles, we've got to think most gym activities are very sagittal plane based, and that's a fancy word for basically the muscles that are involved in movement forward and backwards. So your quads, your glutes, your hamstrings, they're all, and hip flexors, they're all about moving forward and backwards, and they're often our biggest and most powerful muscles. And they're generally the ones that you're most likely to train in the gym. And that's an excellent idea. They're really important to, build up strength, build up muscle mass. But we've got to also think the other muscles that do lateral movement. So in the coronal plane, we call that. So side to side, as the person's experiencing pain with, but also the muscles that do rotation and really importantly, counteract unwanted movement. In this case, that counteracting of unwanted movement is that gliding that I mentioned earlier about the hip ball gliding around the socket and closing down the space. It's the external rotators that stop that unwanted movement. So we've got to think, okay, with our lower leg training, with our lower body training, how do we also strengthen those muscles? And that's going to be from things like side steps with the band. It's doing, kind of the pissing dog weighted stuff to build up the strength in the external rotators. I really like the banded side steps with the band around your feet. If you have rubber ones, you might break a few of them. So if you have the fabric ones, they're really good. But the reason being, if you're keeping your feet parallel as you step side to side and the band is across your feet, that's going to be an isometric, so contracting but not moving, external rotation exercise, which is then going to build up the strength of those muscles that stop the ball from moving in the socket. Does that make sense?
Sorry, yep, I was muted. Yep, absolutely.
So yeah,
makes sense.
Yeah, lateral side step. You're getting the hip,
but you're having the band go
glute medius
go,
and minimus.
Yeah,
yeah, across your feet. So keeping your feet parallel, and then getting the band across there. So if the band overcame your muscles, it would pull you into that sort of pigeon toed, and so you're having to use your external rotators to isometrically hold you there, while also doing the lateral side stepping, which is really working on those coronal plane and transverse plane, i.e. side to side movement and rotational movement muscles that develop that stability to keep the ball in the middle of the socket while we're doing powerful movements.
Yep. Yeah, awesome. All right. Well, that's great info, Phil. Thanks so much. Where can people find you if they want to work with you online?
Yeah, on social media, I'm Phil White Physio. You can find me most places. And then my website is philwhite.me.
philwhite.me. So if you want to work with Phil online, he can work with you unless you are in the United States, unfortunately, for insurance purposes. So sad for all our US members, but everybody else in the world, you're good to go. And we are actually
always happy to answer questions, and so put in questions and happy to share as much information as I can. And obviously I was a bit technical today, but hopefully it made enough sense. So ask any follow-up questions if you have them.
Phil also has a lot to do behind the scenes with what Yanni and I do with the UMS. We've been working together for over a decade now. And so for those of you that are working in the UMS with me, anything to do with your injuries, I'm communicating with Phil and, confirming that my course of action is the right course of action. So you guys have always got him sort of looking over you. All right, Phil, thanks so much. We're going to be coming back. For those of you watching on YouTube, we're going to come back pretty much in 2 minutes. We're just going to end this live stream and do another one on biceps tendinopathy, because we have had so many people ask about it, and it's not something that I've personally dealt with, so I don't like to answer questions on injuries that I haven't dealt with myself. So we will see you all in just a minute. Thanks, Phil.
No worries. See you next time.